Now, oops. Defibrillators, the AICDs, they do have pacemakers right along with it, so they can do both things. They can detect rhythms like VFib or VTAC and bring a patient out of it. You might get a call for someone who their pacemaker or defibrillator is firing. Interesting enough, and I know there's no scientific evidence to this, and there is no protocol for this. But what has seemed to be working, and we've seen a lot of our physicians go ahead and order when someone's pacemaker is firing. You know, the fentanyl is great because it is going to be painful. So we want to go ahead and, you know, make our patients a little bit more comfortable. But what we've been noticing is when we give them 2 milligrams of Versed along with the fentanyl, it does something to the muscles within the body and actually will make the pacemaker or the heart go back into a regular rhythm for whatever reason, and they're not using, or the defibrillator or pacemaker is not firing again for whatever reason. And like I said, there is no evidence whatsoever on this. It's just that our doctors have been doing it lately, and they've been finding that it's been kind of helping the patients out in the meantime until they can get to the hospital where they can put a transvenous pacemaker in at that time. So now there's problems with the pacemaker that people actually have to watch out for. I mean, batteries, yes, batteries will go ahead and fail at some point in time, and that could be deadly. But when they go in and they have their pacemakers checked every so often, they put a little electrode up to it, and they'll go ahead and be able to read the battery life yet. They can see if the battery wear and tear is going faster or slower than what it's been set up to do. You can have broken leads or leads that come out or get pulled out for whatever reason and put out of position, and they're not able to go ahead and shock the patient like they should. Some of the things, though, that we can have interference, you know, power generators, arc welders, powerful magnets. As a matter of fact, they used to give a donut magnet to the patient, and it was such a powerful magnet that if a patient had a runaway pacemaker where it just kept firing and firing, they could take the magnet and put it over the top of the pacemaker, and it would basically shut it off. They used to actually have us do that when we were putting someone in cardiac arrest to stop the pacemaker from firing so that we could mainly do our jobs. Stereo speakers, metal detectors also can go ahead and cause interference. So, changes in patient condition that requires a pacemaker. Maybe, you know, their heart rate has now dropped, or it's dropping too low. Maybe they will go ahead and bring down the rate for a little bit. Electrolyte abnormalities also can be an issue for these patients. So, when you guys get a call, most of the time, patients are going to go ahead and complain of their pacemaker defibrillator is firing. They can feel it. Pacemaker is uncomfortable, defibrillator is usually painful when they go ahead and are shocked by it. And that's why you guys get the calls. But people that actually have issues with their pacemakers or defibrillators can have other signs and symptoms. You know, their cardiac output could be dropping, so they can have the altered mental status. Lightheadedness, weakness, dizziness are very common. They might feel palpitations if their heart rate is going too fast and the pacemaker is unable to stop it. Shortness of breath, chest pain, or one that I find pretty fascinating myself is they'll have hiccups that do not stop. No reason why, it's just that it seems to be an issue for some of these patients. So when we go ahead and we pick up a patient who has been experiencing their defibrillator or pacemaker going off or not working like it should, we always want to make sure we have them on the monitor. And again, we're looking to see, do they have a pacer spike or not? If they don't have a pacer spike, their pacemaker, something's probably wrong with it. We will treat all of these patients and follow all the arrhythmias just like we would normally do for any other patient without a pacemaker. We're gonna, you know, if they're VTAC without or with a pulse, using adenosine or amiodarone for these patients, trying to get the ventricle to go ahead and calm down. If it's a bradycardic rhythm and they're very slow, we could actually put our pacemaker on and try and speed up the rhythm a little bit. Now, left ventricular assist devices. These are becoming very common. Let's see, Condell does them, North Shore does them, Christ Hospital does them also, and I think that might be it right now. I could be leaving somebody out. The most common type right now is the HeartMate-2. There's the DuraHeart, which is under FDA approval. HeartWare just got FDA approval a couple years ago, but it's a pump within the heart, or pump within the body. They have some tubing that's sewed into the left ventricle here, and then a tubing, corrugated tubing, goes right up to the aorta, and it's continuous pumping action from the heart. There's basically the electrical cord that keeps them running. The drivetrain comes out of the abdomen, usually over on the right side, and you need to kind of assess that area for any type of infection. And then it hooks to a controller box, and then you can see the batteries on the side for this patient. People, they go with an LVAD for various reasons. One, they're waiting for a heart transplant, and we know heart transplants are few and far between. And so they'll put that in temporarily. Usually when the ejection fraction gets down to less than 20, 25, that's when they like to go ahead and put this in, because then they can have the heart work with the pump to go ahead and send blood throughout the rest of the body. Other people will do it just to live out the rest of their years. They're elderly and they probably don't have much time left in life, and so they will have an LVAD put in instead of getting a heart. Someone with severe heart failure might be an example of why they would need an LVAD. There was actually a woman, she was 32 years old, and she had some complications with her heart during her pregnancy, and so they put an LVAD in her instead of doing a heart transplant to get her through the pregnancy. Once the pregnancy was over, they were set to do a heart transplant on her. She actually chose to go ahead and stay with the LVAD because she didn't want to take all the anti-rejection medications and everything. And she's had it in place now for almost 13 years, and I think that's the longest one that's been in place up till this date for them. So. But yeah, here's a couple different types. So the HeartMate-2, which is the most common one, goes right to the left ventricle there, so blood will exit through that area in the left ventricle, go through the pump, and then goes up to the aorta. And then here's the HeartWare. Now the HeartWare is got a little disc about this big with a stem on it, a metal stem. And that metal stem is inserted right into the left ventricle. And again, the corrugated tubing goes up to the atria. And this one is the DuraHeart. Same type of situation. This part goes into the left ventricle, and this one can go right up to the aorta. There's other types of LVADs. There's one called the BiVAD, which actually has a part that goes to the right ventricle and to the left ventricle. So it's continuously pushing blood throughout the whole entire heart. LVADs have been around for many years, probably, good 20, 25. They used to have them that when the drivetrain came out and is hooked to the battery, it also had like a little bulb syringe, like what you see on the end of a blood pressure cup. So if for some reason if the pump stopped, you could actually go ahead and pump the patient's heart on their own manually until you were able to get them to a facility that could go ahead and take over and they could fix the LVAD itself. So that was always pretty good. The patient would be sitting there pumping their own heart, or you'd actually have to help them out. So there's a bunch of different components here. Like I said, you have the pump. You can hear that right up underneath the left rib cage. The best way to find out is the pump still working is taking your stethoscope, putting it up over that left upper quadrant, and hearing the whirling sound of the pump. As long as you're hearing the whirling sound, blood is going to circulate throughout the body. If there's any problems, the pump fails, you'll hear nothing. You also want to take a look at the controller. Now, each one of these patients will have a black bag. In the front is a list of all their medications and a list of the bag coordinator's phone numbers that you want to go ahead and call if you're able to. And then it'll also have an extra controller in it, extra batteries. They also have what they call a power-based unit. It's about the size of a boot box that you get your boots in, and that's where they go ahead and charge their batteries, and it plugs right into the wall. I highly recommend, and I tell everybody this, if you are transporting someone with a bad system, you want to take that power-based unit with you in the ambulance. Don't rely on family members to go ahead and do so. There was a situation up at Winthrop Harbor. They actually had 3 patients at one time that were all on the LVADs, and the wife, she went ahead and says, I'll take that